And the recording, starting the broadcast. Good afternoon, everyone. Welcome to, thank you for joining us for today's webinar entitled Extending the Continuum of Care, the Need for Outcomes Data and the Role of Telehealth Technology in Recovery Support with Dr. Kimball. Before we begin, I'd like to make sure everyone can hear me okay, so please just type the word yes in your question box if you can hear me. Great. Okay. So each attendee is in listen-only mode to avoid having background noises that might distract you from listening to our webinar. And throughout the presentation, a staff member will be managing the chat and question box on your GoToWebinar control panel, so you can submit questions at any time during the presentation. Dr. Kimball may be answering questions throughout the presentation, so please just submit at any point in time, and then we will send them to Dr. Kimball. There will also be a Q&A session at the end of today's presentation. So the American Mental Health Counselors Association, along with Aetna, the Texas Tech University Center for Collegiate Recovery Communities, and MAPHealth Management are bringing you this webinar today, and we are very happy to all be partnering together. AMCA is an approved continuing education provider for the National Board for Certified Counselors, and this webinar is 1 hour long, and therefore attendees will receive 1 continuing education credit. In order to receive the credit, you should be on the call for 45 minutes or longer, and all attendees will receive the recording of the event, a copy of the presentation, and their CE certificate in a follow-up email on Tuesday, June 28th. If you have problems or you don't see that, that email that you on Tuesday is a follow-up with all of your information, how to access your CE, the recording, and the presentation, please just shoot us an email. My email address is webinar@amhca.org. You can send me an email and just let me know that you are having some issues with it or you haven't seen it, and we will make sure we get it out to you. So without any other further ado, I'm going to pass the presentation on over to our AMCA CEO and Executive Director, Joel Miller, who is going to introduce Dr. Kimball. Joel?
Thank you very much, Whitney. And I'd like just to reinforce what Whitney just mentioned. We're very excited, very pleased to be co-sponsoring this event with Aetna and the Texas Tech University Center for Collegiate Recovery Communities and MAPHealth Management. We're very pleased to be partnering with all of those organizations, and I'll just try to be brief. I'm just going to initially introduce here Dr. Kimball and then just make a couple of comments about the focus for today's event. But first of all, very excited, very pleased to introduce Dr. Thomas Kimball, who is the George C. Miller Family Regents Professor at Texas Tech University and the Director of the Center for Collegiate Recovery Communities at Texas Tech. Dr. Kimball has received numerous teaching awards for his courses on families, addiction, and recovery. He is the author of several peer-reviewed articles on addiction and recovery and has consulted and presented on recovery-related issues across the country. And he is also the co-author of the book, 6 Essentials to Achieving Lasting Recovery at Hazelton Press. So with that in mind, I briefly want to mention that this particular webcast will focus on the importance of extending the continuum of care for those in addiction recovery, the unique opportunity and challenges of counselors providing recovery support services will be highlighted and articulated and discussed on this webcast. And in addition to those areas, the need for longitudinal outcome data within the addiction recovery field will be addressed as well. The role of telehealth and technology can play in providing recovery support and simultaneously gathering longitudinal outcome data. So with that, I'm really pleased to turn this over to Dr. Kimball and his comments. Thank you again.
My pleasure. Thank you for that introduction. So grateful to be here to take a little time and talk about some things that I'm really passionate about, and to tell you a little bit about my experience. Again, I'm happy to field brief questions as we move along, and hopefully we'll have some time at the end to dig into some deeper questions. By way of introduction, let me just tell you about a few of the hats that I wear in my professional life. I am, as was said, I'm the director of Texas Tech's Collegiate Recovery community, and in that role, we provide recovery support services to 125 students in recovery. And people ask me, well, what does that mean? And really what that means is that we provide specialized recovery support or specialized support, much like student athletes or veterans might receive on a college campus. As many of you know, college campuses are really adverse environments for people who are trying to stay clean and sober, just based on how much drugs and alcohol are accessible on college campuses. And so when somebody finds recovery, it's really important and helpful to them that they have a particular community of support, a place to be, a place to receive help for academic advising, emotional support, a community of like-minded individuals to be with. And so that's one of the hats that I wear. And in fact, there's a great collegiate recovery movement happening across the nation where more and more of these programs are being developed on major college campuses across the United States. The other hat that I wear is I'm a co-clinical director with MAPHealth Management. In that, I provide support and consultation to our recovery support efforts. We have many peers in recovery, certified and trained peer support specialists that provide just the kind of support we're going to be talking about today to people in recovery. And we're going to talk about the opportunity for counselors to provide that support and to extending that continuum of care. At MAP, that continuum of care is extended from 12 to 18 months post-treatment. And then I also have helped in developing and refining our data gathering process, including analyzing that data as we're learning more and more about how people stay clean and sober and in recovery over a lifetime. All of that really sets up a couple of questions that I'm really obsessed with. It's kind of interesting to talk about obsession when we're kind of talking about addiction and recovery. That's funny. I hope you laughed at that. Some of the questions that I've tried to find answers to in my professional life is how do people stay in recovery over a lifetime, as you see on the slide? If we expand that out, what are the factors that help people stay in recovery for a lifetime? So not just how they do it, but are there factors that play into people being able to stay in their long-term recovery? What are their characteristics? Are there attributes that people develop as they and foster as they move into long-term recovery? It's another question I think that is important to consider. What do people in long-term recovery do to be successful? So what are the actions that they take? And what are the different pathways of success? At our Collegiate Recovery Program, we embrace an abstinence-based model, particularly a 12-step model. But are there other pathways of success for people in recovery? For people that may not respond to a 12-step model, what are the core elements, the key elements that all these pathways have in common? And are there different pathways based on things like drugs of choice or age or race or social and economic status or a host of other variables? Could we learn a lot if we gathered data? Could we learn how we might help a 18, 19-year-old male who is a heroin addict that might be different if we help a 50-year-old alcoholic who is pursuing recovery? Are there differences just based on who people are as far as the pathway is concerned? That's all ahead of us as we learn more and more about recovery, as we learn more and more about how to provide extended support to them, and also how do we gather data, and how does that data how should that data that we gather, that information that we gather, inform treatment and recovery support moving forward. So that's just a little bit of an introduction to me and how my brain works as far as the questions that I'd really like to have answers to. And so let's just kind of move forward here. I'm going to approach this webinar and make the case that addiction is a chronic brain disease. We won't spend a lot of time for me trying to convince you of that, but there are a couple quotes here. One by the National Institute of Drug Abuse is, addiction is defined as a chronic relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences. It is considered a brain disease because drugs change the brain. So there's this idea that when somebody begins to use drugs, and oftentimes people use drugs very, very early in their lives. So if you took a survey of my students, my undergraduate students, and you said, okay, at what age did you begin using alcohol and drugs? The average age of them beginning to use would be 9 years old. So you think about the kind of brain development that takes place between 9 and 25, for example, where most people consider people's brains to be kind of fully formed, particularly the prefrontal cortex, the front part of the brain that kind of separates us from the chimpanzees and the gorillas. In that front part of the brain is where things like hope and spirituality and moral reasoning reside. And so if someone starts using drugs and alcohol, I'm just going to, just for today's webinar, let me just say, when we say drugs and alcohol, it's an artificial separation. Alcohol is a drug. But most people kind of distinguish those two, which is kind of arbitrary, I think. But when somebody starts using drugs at 9, it changes the way that their brain actually develops. It changes the structure and function of the brain. I believe that addicts and alcoholics, or people that are predisposed to become addicts and alcoholics, actually brains are different from the beginning. That many people have what I would call an overactive midbrain, and I'll talk a little bit about that in the next slide. These brain changes can be long-lasting and can lead to many harmful, often self-destructive behaviors. We all know and love people who have been addicts and alcoholics who engage in behavior where we just go, it doesn't make any sense. Nobody in their right mind would do the things that they're doing. And the answer to that question is, well, it's because they're not in their right mind. They actually have a chronic brain disease. Nobody in their right mind behaves like an addict or an alcoholic. And it really leads towards this idea about a chronic brain disease. From the American Society of Addiction Medicine, addiction is a primary chronic disease of brain, reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestation. Now, I want you to pay attention. One of the most important components of these two quotes is actually the word chronic. And whether you agree that addiction is a brain disease or not, I think we can all agree that addiction or alcoholism is a chronic condition. And the fact that it is chronic in nature logically leads to the importance of extending the continuum of care. And typically, that continuum of care isn't long enough for people who have sought treatment and are now coming out of treatment and needing longer-term support. And we'll talk about that as we move forward. Back to the quote, this is reflected in an individual pathologically pursuing reward or relief by substance use and other behaviors. As we move to the next slide, I'm going to particularly talk about this idea at relief. Now, that's a great picture. Come on. Doesn't that just kind of like scare the hell out of you right there? That saber-toothed tiger. And one of the things I want to kind of use is this metaphor of the saber-toothed tiger and really talk about threat, stress, and survival when it comes to addiction, when it comes to alcoholism. I believe that addicts and alcoholics were actually built for an earlier time, that the midbrain, which is parts of the midbrain which really are core to our survival, and really help us to understand threat and stressful situations. Addicts and alcoholics' midbrain is, I believe, is overactive, which means that back in the days of cavemen and women, you had, if the grass moved, those folks were already running because they knew that when the grass moved, there was a saber-toothed tiger in the grass. And so just by way of survival, it's, okay, we got to get out of here or we're going to get eaten. And so we fast forward to today, we live in this environment where most often there isn't that kind of threat happening to us day to day. But addicts and alcoholics still feel that under threat in that way, and they still feel under stress. And so if you are walking around every day feeling under threat or under stress because of an overactive midbrain, then a lot of times our brains are so strong that they begin to project the threat. So I don't know if you've ever done counseling with somebody who's in early recovery or who is struggling in their addiction, and they really have a great partner, but all they see is that their partner is a threat to them, even though the partner is not. And it's almost like they presume a threat because their midbrain is telling them, you are under stress, you are under threat. And so the people around them in proximity become the source of that threat, even though they're not. And so that's why when we think about the chronic nature of addiction, we need to talk about families and not only providing support for individuals in the continuum of care, but also those that love those individuals who are feeling under threat and stress. Now, when somebody feels under threat and stress and they use alcohol or another drug, depending on their chemistry in their body and whatever their drug of choice is, it calms that threat. It calms that stress. It is the solution to that feeling of being under threat. So when they use, they feel like normally they would feel. They feel less stressed. They feel unthreatened. And the brain very quickly latches onto that and says, we need this feeling to survive. And so very quickly, using moves up the survival needs, and eventually it becomes one of the most important survival needs. Our survival needs being 1, air to breathe, 2, water to drink, 3, food to eat, roof over our head, love. Some people would put sex in that survival need. But if you've done any work in this area, you know that addicts and alcoholics use under threat of those other survival needs. So somebody would choose to use drugs and alcohol over having a roof over their head or even eating. Their relationships, love and sex, go by the wayside. That's because using becomes a higher priority. And because addiction and alcoholism leads to death, many of them would prefer to use rather than to breathe, as we see overdoses and a lot of damaging effects that addiction has on so many people in this country, so many people that we love. Each of us have been touched by this disease. Many of us, even in this webinar, have lost people to the disease of addiction and alcoholism because of its chronic nature. So I hope you understand, hope you got that metaphor about the saber-toothed tiger. It's actually a metaphor that my co-clinical director at MAPHealth Management gave me. His name is Dr. Kirby Stewart. He's a brilliant man, and it just makes sense to me when we think about addiction and alcoholism. Because of the chronic nature of the disease, what it means is that use events are likely, and so we use different terms. We call use events versus relapse, etc. I'd like to distinguish use events from relapse and say that use events actually can be a one-time event, and relapse actually means a return to an addiction lifestyle where it becomes again a primary survival need. I actually like to think of it in like 3 categories, and I can't remember who first said this, so I will reference the unknown contributor, but I like to think about it as a lapse a relapse and then a collapse. A lapse is more like a use event. It's a one-time deal that happens and somebody reaches out for help very, very quickly. A relapse is a much more elongated kind of deal. And a collapse is when somebody's just rolling again in their obsession and compulsion, and also in their use and behavior. And so the chronic nature of the disease is just helping us to understand the importance of this continuum of care. And if you look down at the graphic there, you'll see something from the Journal of American Medical Association and the National Institute of Drug Abuse, comparing what they call relapse rates between drug addiction and other chronic illnesses. So you've got drug addiction, type 1 diabetes, hypertension, asthma, and we can see a very similar pattern with chronic conditions, that people more often than not kind of have these moments and lapses and difficulties, sometimes that can be really dangerous and even deadly. But it's natural for us to return as human beings, because change is hard. We typically don't wake up and say, "Oh, I'm going to overcome my greatest weakness today." How many of us have had New Year's resolutions that have gone by the wayside very quickly? That gives you a sense about, with chronic issues, how difficult it is to maintain for long periods of time somebody's recovery. Does it happen? Do people find recovery and stay in recovery and never have a use event or a relapse or a collapse? Absolutely. It happens all the time. We just have to understand, when we extend the continuum of care, we're going to deal with use events, and we hope that they stay at use events. And as we have connection with people, perhaps we can even prevent use events from turning into complete collapses. A study from 2007 kind of helps us understand and predict how extending abstinence, let's call it, or extending recovery actually predicts long-term recovery or increases the probability that people stay. So in this study, the number was about 1,200 people. 1/3 of people make it to a year, which is really typical for this field of recovery. You know, people like to talk about 1/3 of people come right out of treatment and use, and then another third of people are in and out of recovery, and then another third actually make it to that year. If you achieve that year, it actually decreases your probability of relapse by 50%. So if you make it a year, then 50% or less will relapse. And then if you make it 5 years, only 5% of those 5 years will actually make it. 15% of those 5 years will actually relapse. Now that means that some of the people who make it 5 years continue to relapse. It's a little bit interesting that we've taken other, and I'm going to compare it, and some of you may feel it's a stretch to compare it to this, but I don't think so. 30 years ago, if we look at childhood cancer, I have a son who's a cancer survivor. He was diagnosed just shy of his 4th birthday. He's now 18, just graduated from high school. We're so grateful for that. I had this moment as a dad, any of you that have had sick children can understand, where we went through this really difficult experience with him going through treatment. And then he graduates from high school, and he plays the trumpet. So he's playing the trumpet he's playing the Star-Spangled Banner at the front of this graduation, and then he walks across the stage as a high school graduate. So, I'm crying like a baby, but as this is happening. But one of the reasons that he was able to do that is because 30 years ago, childhood cancer took 8 out of 10 kids. So 80% of those kids that got leukemia specifically, they died of their disease. And then everyone got together and they engaged in data gathering and research of all these kids that were entering cancer treatment. So when my son, 14 years ago, got into his cancer treatment, he was randomly chosen to engage in one of the arms of the research on childhood cancer. He was put into the standardized arm, and then there were 2 or 3 other kind of test arms. And as soon as they find out that one of the arms is better than the other, then that becomes the standard. So in a period of 35 years, we've been able to flip that success of childhood cancer on its head. And now 8 out of 10 kids with leukemia live instead of 8 out of 10 dying. We need a revolution like that in the recovery field. We have not been very good as a field at gathering that data collectively across a number of different providers and then having that care inform the pathways of recovery. If we did that, then that first bullet, that 1/3 of people make it to a year, we could actually spin that 2/3 or 80% actually make it to a year. And then as we move forward, we can see that 50% of them or less would relapse. And then we could see that if we could extend the continuum of care and provide support up to 15 years, you know, we might be able to even make that number smaller so that more and more people stayed in recovery over a long term. Imagine the impact of putting those kinds of numbers for people in recovery on their head to our society, to our cities, to our families. And that is where we are in the addiction recovery world. We have an opportunity to do that, not only provide support, but also to gather data to help flip that on its head. So let's get into, as we move forward, a little bit more about the opportunity and challenges for counselors providing recovery support services. So let me just get some definitions on the table. Recovery from alcohol and drug problems is a process of change through which an individual achieves abstinence and improves health, wellness, and the quality of life. Recovery, this is SAMHSA's definition, and the field has gone through some arguments about what recovery is. Everybody has their own definition. But really, recovery is a growth process. It's a growth process in order to learn how to manage and cope with that feeling of threat and stress in more productive ways, to develop what I would call healthy coping skills. And as people do that, they improve their health, their wellness, and their quality of life. And so one of the questions that we ask is, how long does it take for the brain to heal? And one metaphor that a brain surgeon gave me, who happened to be in recovery, he said this. He goes, in order for people to understand how long it takes the brain to heal, I use this metaphor. So if I was to ask you all, how many of you are right-handed versus left-handed? And then I said to you, okay, if you're right-handed, now you have to use your left hand for the rest of your life. And if you're left-handed, you always have to use your right hand to do all the things that your dominant hand would say. So you have to use your non-dominant hand. And then he said this, how many times would you have to go to your non-dominant hand meetings, or talk to your non-dominant hand sponsor, or visit your non-dominant hand counselor? How long would it take for you to, using your non-dominant hand, for that to feel normal? What would it feel like in 2 weeks? What would it feel like in 30 days? What would it feel like in 6 months? What would it feel like in a year? And even after 25 years, if somebody gave you a pen and said, sign your name, would you find yourself putting it in your dominant hand and going, oh, wait a second, I have to use my non-dominant hand? That's kind of a silly example, but it helps us to realize that the kind of improvement, the kind of this change, the difficulty of the change that people in recovery go through, anybody in recovery ought to garner our respect and admiration for what they have to do every day. Recovery support is a proactive means to support a person in recovery. We'll call them a peer, from addiction and other behavioral health disorders. So recovery support in a broad sense could be for people that are alcoholics or addicts in recovery, or have co-occurring addiction and some kind of mental health disorder, or somebody that just has another behavioral health disorder, or a behavioral health disorder alone, like an eating disorder or depression or anxiety. Recovery support in this way that we're talking about could be any one of those populations. And the primary goal of recovery support are to detect early signs of risk of decompensation. We could put use event or relapse, but decompensation is a decompensation from a place of recovery to that place of use event or lapse or collapse or relapse, and to guide the person at risk back to wellness and healthy recovery. All right, so we're trying to figure out how to detect signs of risk that they might be in trouble before the decompensation occurs, or as the decompensation is occurring, before something more difficult happens. And if we think about recovery support broadly, it's not necessarily an add-on service, but in that way, we can think about it as an overarching umbrella, which includes any number of interventions and services, including treatment, counseling, and specific post-treatment support. And as we move forward, we're going to be talking about that specific post-treatment support. But remember, recovery support could capture all of those things in an umbrella. Now let's talk a little bit about peer recovery support versus professional trained clinicians or counselors or therapists. You know, traditionally, when we think about recovery support, many people think about peers providing that kind of recovery support. This would be somebody that, for example, somebody in recovery being supported by somebody in recovery that's a little bit farther ahead of them in the process. I'm not talking about sponsorship. I'm talking about a peer offering a specific kind of support. And but now we're talking about like a professionally trained counselor providing that support, which would fit your category and mine. That there is a place, there is I think a huge need for professional trained counselors to know how to understand how to provide recovery support, and there's an opportunity, I believe, that will continue to get bigger and bigger for you to be actually reimbursed for that kind of recovery support services that can be added. And so I think that there are probably some distinct differences and challenges for counselors versus peer recovery support, the greatest being that people who are, particularly people who are addicts and alcoholics, often relate really well to somebody else who's struggled with that same thing. Now, many of you are very gifted at breaking down those barriers with people in recovery and working very well with them. And what I found as a counselor and as director of our Collegiate recovery program that happens not to be somebody in recovery is it's much more about those just general counseling skills of caring and listening, et cetera, et cetera. And we'll talk a little bit about the frame in which we take as we move to this next slide. What we found in our work, in my work at the Collegiate Recovery Program, and also with MAPHealth Management, with our recovery support specialist, is that a strength-based approach to recovery support is the most effective. And I've just listed some of the things here that counselors need as they think about and move into providing recovery support services. As many of you know, strength-based advocates believe that the most effective forms of help come when focusing on a person's capabilities, resources, and competencies to meet and overcome the challenges of life. And so this is a move away from problems, move away from diagnoses. This is a move away from confronting negative ways addicts and alcoholics, and really understanding that people in recovery, or people who are making that transition from addiction to recovery, have a number of capabilities. They have a number of resources and a number of competencies that will help them to meet the challenges of recovery. And this is almost like, in these quotes, it's almost like an assessment of the capacities for recovery. Meeting people where they are and helping them figure out what the next right thing is to do, and helping them see and believe in their capacities to meet the challenges that they have, and getting help and support around those areas that they need to strengthen. Counselors from this approach believe, and this is kind of a, is this is this area for me checklist? Some of you already know it is, and others of you are maybe thinking, hey, you know, is this something that I could do? So here's a little litmus test for you. Persons in recovery, counselors coming from this approach believe that persons in recovery are experts in their own life and experience. Persons in recovery have unique strengths and gifts to meet the challenges they face. Persons in recovery have a natural desire to succeed, which is really an interesting one. Do we believe that somebody that is embracing a recovery, they have this natural desire to be connected, as the point says below, that they crave healthy relationships. They have a natural desire to be well, that they have a natural desire to get well. When somebody finds healthy relationships and connectedness, something really wonderful happens in our brains, particularly in that prefrontal cortex. We crave connectedness. We crave being in relationships of vulnerability. And when we're in relationships of vulnerability that are safe, that are, for lack of a better word, secure, those of you attachment believers out there, then something really amazing happens inside of our brain. We feel that. We feel belongingness. We feel emotional connection. So as we've done research on collegiate recovery programs, the two most important elements that the students themselves acknowledge and recognize is two different kinds of support. One is affiliational support, and the other one is emotional support. So let's think about that for a minute. So here's young people in recovery, emerging adults, 18 to 25-year-olds, most of them. And so what they're saying is one of the most important components of being part of a community of support is that I feel affiliated with something. I feel like I belong to something bigger than myself, in this case, a collegiate recovery program. And I get emotional support when I'm there. And so in a recent qualitative study that I finished and I'm writing up, it's interesting because the collegiate recovery students talked about connectedness in a couple of ways. The first one was about hope. So they felt hope when they saw hope in people who were like them but ahead of them in the process. And so hope becomes, if you think about strength-based, hope becomes an incredibly important component to this connectedness. Hope that I can overcome. Hope that I have unique strengths and gifts to meet the challenges that I face. Another thing that was really important to them was this idea about coping. Right? So hope and coping become really important for people who are early in their journey. Right? But a lot of that has to do with, hope has to do with connectedness. And if you think about a 12 steps approach, a connectedness to something greater than yourself, a higher power, a God of your understanding in the language of the 12 steps. But it's also connected to having relationships with others. These emerging adults in recovery said they first found a connection to their higher power when they felt connected to their peers. So it was first a connection with their peers, and then they felt connected to something bigger than themselves. Very rarely was it the other way around, that they felt connected to a higher power and then felt connected to their peers, which is just an interesting thing to think about. And as recovery support providers, that connectedness becomes incredibly important. Their connectedness with you and your ability to help them to become connected with their people, for lack of a better word, their tribe, where they can feel that connectedness. And then the last point, persons in recovery challenges are seen as opportunities for growth, development, and capacity enhancing. Counselors who provide recovery support have to be really good at I was going to say spin. That's very political, and I don't mean it that way, but you understand what I'm saying. They have to spin these challenges into the language of growth, development, and capacity enhancing. The language that we use to help people in recovery see their challenges as these opportunities for growth desires to succeed, the capacity enhancing, the capacities for recovery, the language becomes incredibly important. And then as there's connectedness between the person that you're providing recovery support for and you, that your own language becomes very powerful to them. And they begin to adopt those same kinds of languages, I think, in a really powerful way. Some of the counselor characteristics, empathy, and the ability, look, if you don't have some of these counseling characteristics, if we don't all have some of these counseling characteristics and we want to be counselors, therapists, then maybe we're not even in the right profession. My guess is that y'all have these capacities, these characteristics. Empathy and the ability to, and patience to engage in empathic listening. Hopefulness and the ability to inspire hope in others. We talked about that. Compassion and the ability to express this compassion in interactions with others. Communication skills, the ability to express oneself, particularly when we think about this over the telephone and video conference formats. It's a different vehicle. But what we've learned, and we'll talk about this a little later, is that it can happen. You can actually do really good recovery support over technology, telephone, and video conference formats. Again, discernment and the ability to discern and highlight the strength of others. This last point, I always take a chance when I talk to counselors. I always take the opportunity to talk about self-care. I think it's particularly important when you work with people in recovery. I think that particularly people who are early in recovery can be exhausting. That is I'm not meaning that to mean that they're not fantastic people, but they just need a lot. They just need a lot of attention. They need a lot of hopefulness, and they need a lot of people around them that are feeding them those positive kinds of things. And so the importance, if you choose to work in this arena, those of you that have worked in this arena before, you know that you need to take care of yourself. You need to practice that good self-care. I'm a big believer in meditation and in exercise and eating right. Whatever you do to take care of yourself, make sure that that's always in place. And I would just say that generally. We as counselors and therapists really need to take care of ourselves so that we can be the best for ourselves, our families, and for our clients. So let's move on. So I alluded to this before. Historically, recovery support has been provided through in-person, face-to-face interactions. What we've learned over the 5+ years we've been at MAP doing this work is that you can provide recovery support through a software platform utilizing telesupport or video support mechanisms, and just broadly using telesupport or video support mechanisms. The software is really, really helpful in that it it formulates not only the rate at which recovery support is offered, but also when we get to data gathering, it becomes incredibly important. When using technological application, it is crucial to maintain person-to-person, either peer-to-recovery advocate or peer-to-counselor contact versus person-to-computer or cellular phone application. This point is simply to say we can't lose track of the person-to-person contact. There are some movements out there that are using a computer or cellular phone application to provide recovery support services. That, I believe, is dangerous. We have to maintain the person-to-person, in this case, peer, person in recovery to counselor contact. Whether it's using technology or face-to-face, we all know that there's something happens when two people talk to one another. Two people, one person as the counselor provides support to the person in recovery. We can't lose that even in the midst of technology. The use of technology to provide these services is effective and user-friendly. And the other thing that it does is it has the capacity to expand our ability to provide recovery support services regardless of where somebody is in the United States or throughout the world. Somebody could be living across the pond and could be given recovery support services. In our rural communities, it's so important that when somebody comes out of treatment and then goes to live in a rural community that they could get recovery support services. We have technology now in effect that allows providers to utilize counselors who offer services in the state in which the discharged patient resides. So let's imagine that a treatment provider is having so many graduates from their program a month, and they happen to come from various parts across the nation. Well, the technology is now in place where those people could be referred to a counselor such as yourself, and they could get recovery support services, and those counselors could build third-party payers for those services, and they could be in the state in which the discharged patient resides. So treatment facilities can, through this technology, expand their continuum of care using people who are already in place in the communities in which the people are discharged, in the state in which the person is discharged when we think more broadly, and provide effective, amazing, important recovery support, extending the continuum of care, particularly 12 to 18 months post-treatment during the most vulnerable times. Would we want 5? Absolutely, but 12 to 18 months particularly. Now, there is, as people provide recovery support, like I talked about with cancer treatment, all these providers got together in the cancer treatment world and utilize similar mechanisms of cancer treatment, and then gather data on all of these people across the country, all of these kids who are going through treatment across the country. We have an opportunity to do that, to provide long-term recovery support and learn as much as we can through gathering data. Some of the data can be gathered passively, which means that it could be gathered via, if somebody went to treatment, through their intake, through their assessment. But what we need is longitudinal data, following people over time to understand and answer some of the questions I asked in the beginning. One of the great challenges that we've learned from MAP is there's this balance of providing recovery support and gathering data. That, of course, recovery support comes first. Gathering data is just a secondary benefit by balancing recovery support. If you spend an hour with somebody asking them about the recovery, providing recovery support, you already have a ton of information about that person, and with their permission, of course, and consent, you can then input a lot of that data into a system by way of just gathering data by what you do. By just being with somebody, by asking them the appropriate questions, you gather data naturally. We do that as counselors. And if we had an easy way to input that, we could gather tons of data on people in recovery and moving forward longitudinally. Also, what we've learned at MAPHealth Management is there are specific characteristics, specific questions that actually assess risk. And so as we get more and more data, we're becoming better at knowing the questions that need to be asked to help somebody understand the risk level that they're under, the probability that they might relapse in the next 30 days or the next 60 days. We have that technology now to actually assess risk based on a person's characteristics and the answers to a certain set of questions, which is actually quite remarkable. One of the things that we did recently is that we did a study on retention rates based on 5 years of our data. And the results are promising that we've put out in a white paper that I'll give you the link to in just a second. And I'm going to move through these quickly, so if you have any questions. But what we found is that if you look at that first point, it is generally held that addiction treatment facility alumni retention rate range from 5 to 8% at 6 or more months. What that means is if most treatment facilities have some kind of alumni coordinator, some kind of alumni services where they provide maybe groups in different places, or they try to keep track of the people that have graduated from their facility. And at best we can tell, they can keep track of about 5 to 8% of them at 6 or more months post-treatment. So just look at the numbers here with MAP. However, with regard to MAP recovery support services, 90% of participants remained in contact with a MAP recovery advocate at 30 days, 68% remained in contact at 90 days, and 53% contact at 6 months. Are we seeing attrition? absolutely, but not near the amount of attrition that we might see with just alumni services. If we look at 12 months, the number is 35%, which is significantly higher than 5 to 8%. Here's interesting what gets into the connectedness that we talked about. Of the total number of individuals who started with MAP Recovery Support Services, including those who did not complete the program, the average number of meaningful sessions per participant was 26. Of those participants who were actively enrolled in the program at 12 months, the average number of meaningful sessions was 43. So those people that were actively enrolled and completers of the program at 12 months averaged about 4 sessions a month. So every week, those who were successful in completing the program were in contact with somebody who was providing recovery support to them once a week, which really fits a good counseling model. We typically see people once a week, although we may see them less as they do well over time, right? To start with, we may see them once a week, ideally. And so what we found is that this kind of connectedness is really important, that people who do well stay connected to the people who are providing them recovery support. 33% of the total number of participants enrolled with MAP Recovery Support who reported a use event completed the program. So we were able to keep in contact with 30% of those who participated. 33% of them had a use event, and we were able to help them to stay connected after a use event and then be completers of the 12-month program. Of those who reported a use event and completed the MAP Recovery Support Services program, of those 33%, 82% of participants were not using at the time of that 12-month. Now, of course, if they are still using and they want to keep continuing to move forward in the program, that's fine. It's interesting that we're able to keep in contact with somebody who is continuing to use, and we make tremendous efforts to get them to treatment and help, but they stayed connected to their MAP recovery specialist, their support service person, and many of them eventually we were able to get to help, get to treatment or back to treatment or into meaningful recovery again. Some conclusions: based on the knowledge we've gained from our first 5 years of tracking post-treatment recovery support, the key factor is maintaining a connection with the individual. That's where we feel like that counselors that have education and training could really make a difference in this field. That your ability to connect with people, your ability to stay connected with them, could really be essential in keeping more of those people in a continuum of care from 12 to 18 months. Telehealth offers the ability to maintain that connection and expand its reach. Despite a return to drug use or one-time use event, when the connection with the patient is maintained, long-term recovery continues to be possible. It makes sense, doesn't it? If they stay connected, then it's much more likely they're going to maintain it and reach out for help. You can get a copy of the research paper at this link if you're interested in the full white paper that myself and Dr. Kirby Stewart wrote based on our initial white paper. With that, any questions, discussion? I think we have about 7 minutes here before we're at the top of the hour. Looks like I have a question. Did I miss it? Let me open these up. Okay, we have one question. What does what you're calling recovery support differ from strength-based counseling? If so, in what ways? How does it differ from sponsoring? I think that's a really good question. I think that the difference between recovery support and strength-based counseling are very, very subtle. In this case, it would be specific, what we're talking about here, to people who are have been to treatment and are now extending that post-treatment environment, which may not always apply to just someone that you're providing with strength-based counseling. I think it's very, very different than sponsorship. I mean, with sponsorship, you have a different type of relationship where somebody is taking somebody through the 12 steps of Alcoholics Anonymous or Narcotics Anonymous or another 12-step program. And recovery support is a broader kind of support than sponsorship would be. A good recovery support person, a counselor would may ask about sponsorship. You know, how are things going with your sponsor? May even suggest that somebody, you know, what did your sponsor say about that, or have you talked to your sponsor about that? But it's much more about creating a recovery plan and helping people figure out where they're going to focus, what areas they're willing to focus on now, and what are the next right things to do. Somebody asked, what about other addictions such as stealing, gambling, and sex, for example? That's a really great question. I believe that if somebody is using drugs or alcohol or engaging in behaviors such as stealing, gambling, sex, self-harming behaviors, eating disorders behaviors, I believe it may be a function of the brain disease itself. So the use itself or the symptoms itself actually become a symptom of what's happening within the brain. Back to the saber-toothed tiger, feeling under threat, feeling under stress, is alleviated by using a behavior or a substance, and yes, that behavior becomes, or the feeling that comes from that behavior becomes very much a survival need. And we all know as counselors that people use different behaviors to unhealthily cope with stress and threat, and so we have to pay attention to those kind of behaviors. I always believe that addictions are always two-tailed, which if somebody is struggling with some kind of substance use disorder, or as that slips over the line, I think, to obsessive compulsive, addiction and alcoholism, as I understand them, we always have to look for a behavior as well. So it's never one or the other. There's probably kind of multiple arms to dealing with the feeling of stress and threat. We have a question about what is the response from insurance companies to using telephone and telemedicine. I think that those conversations are ongoing. I think that insurance companies, at least the conversations that I understand at MAP, are becoming more and more willing to pay for recovery support services in this way. They're seeing the utility of extending this continuum of care. It makes sense actually from a fiscal point of view. If we as counselors who are providing recovery support can help people continue to stay well, help them assess risk and intervene before they have a relapse or a collapse, which would send them into another treatment event, we could help save lots and lots of resources that could be used for more recovery support to help more people go to treatment. So fiscally it makes sense to the insurance companies. And I think it makes sense to them that you would provide as counselors, as licensed, trained counselors, to provide that recovery support. And there's already mechanisms in insurance companies for you all to actually access them and get that third-party payer. It's just a matter of them allowing therapists and counselors to actually use the correct codes to do that. So I know that MAPHealth Management is in continuing conversations in this kind of discussion and receiving third-party reimbursement. What risks do providers face if they don't track outcomes long-term? That's a great question, and I think that's probably going to be the last one that I can answer. The field is moving towards outcome-based treatment, which means that eventually third-party payers of treatment providers now are going to have to, treatment providers are going to have to show third-party payers, insurance companies, that what they do is effective and that they're using outcome data, longitudinal outcome data, to inform their treatment. We're not have arrived at that day right now, but we will arrive to that day. Every other condition, that I know of has to show some form of effectiveness in what they do. Now, is treatment effective? I believe it is, particularly, there are many providers that provide great treatment, but the treatment field itself has never had to say, this is our recidivism rate, this is our success rate in a longitudinal way. Some of them have gathered that data and have that, but many, many, many people do not. And what will happen, I believe, is that insurance companies will actually say, you have to do this. You have to show us that what you do is effective, or we're not going to reimburse you. Now, we're talking about treatment providers. We're not talking about counselors now. Thank you for the questions. I'm sorry I didn't get to more of them. Appreciate it today. Thank you very much for letting me come and present.
Thank you so much, Dr. Kimball, and thank everyone for attending today's webinar. If you have any other questions, please contact AMCA at webinar@amca.org. Once you leave today's webinar, you'll receive a survey for this presentation. We'd appreciate it if you complete it and provide your feedback, as well as ideas for other webinars that you would be interested in us offering. Don't forget to look for your follow-up email on Tuesday with a recording of today's event, a copy of Dr. Kimball's presentation, and your CE certificate instructions. So without any other business to take care of, thank you again, Dr. Kimball, for an amazing presentation, and thank you everyone for today's webinar. Have a great weekend.